Opioid Use Disorder by Hannah, Lisa, and Emma. Okay, so the pathophysiology of opioid use disorder. So opioid use disorder is a chronic relapsing illness. It's embodied by using opioids chronically and is considered an addiction to these substances. It's associated with decreased health and death to user. How do opioids interact with the body? These natural semi-synthetic or synthetic drugs interact with the body by binding to the kappa, delta, and mu receptors in the body, causing effects such as decreased pain and alertness, decreased activity in the respiratory system and emetic center, decreased GI activity and urinary retention. Epidemiology. So statistics state the following: opioids are often used clinically to decrease pain, especially post-operative, relieve diarrhea, and suppress cough center. Recently, there's an increase in availability of opioids, specifically fentanyl and fentanyl analogs in the illicit drug market, increasing the risk of overdose and death. There's a recent increase of deaths associated with increased usage of opioids. There have also been 1,422 deaths associated with the usage of opioids, which were reported to the BC Coroner Service in 2017. This is a 43% increase in comparison to 2016. Key risk factors for opioid use disorder. So key risk factors include past recurrence of substance misuse, untreated psychiatric disorders, young age, social and family environments that encourage misuse, depression and stress, difficult life circumstance, suicidal ideations, and being of the male gender. Diagnostic parameters for opioid use disorder include so step 1, asking the patient how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons. If the answer is none, you can end the screening. If the answer is 1 or more, you should continue with the DSM-5 opioid use diagnostic criteria. So step 2, it's based on questions, the DSM-5 opioid use diagnostic criteria screening tool. So if the patient scores 2 to 3 positive on the questions, the patient is diagnosed with mild opioid use disorder. If the patient scores 4 to 5, the patient is diagnosed with moderate opioid use disorder. If the patient scores 6 or more, the patient is diagnosed with severe opioid use disorder. This next slide is the DSM-5 opioid use diagnostic criteria tool. As you can see, there are a bunch of questions. The patient will be asked each of these questions, and each of the questions count as one symptom. So at the end, you're going to total up all the symptoms that the patient confirmed with, and based on their answers, mild opioid use disorder would be 2 to 3 symptoms, moderate would be 4 to 5, and severe would be 6 or more symptoms. If it's 1 or less, it is generally thought to not be considered opioid use disorder. So prescription treatment options, there's methadone, which is used for individuals who are trying to slowly get off using the opioids. And then there is buprenorphine or naloxone, Suboxone, which is often used in contrast to methadone to try to reduce the symptoms and effects of opioids. So methadone side effects include higher risk of overdose, increased risk of cardiac arrhythmias as a result of QTC prolongation, drowsiness, dizziness, confusion, changes in blood pressure and hypotension, respiratory depression, increased dependence and tolerance, urinary retention, adrenal insufficiency. Side effects of naloxone include less risk of overdose and milder side effects, palpitations, QT prolongation, hyper or hypotension, blurred vision, meiosis, diplopia, respiratory depression, bronchospasm, anaphylaxis, angioedema, and dependency. What should the client be told about if they experience these? If a naloxone induction is started before a patient is in moderate to severe withdrawal, they will experience a sudden naloxone-induced precipitated withdrawal, which is much more severe than typical withdrawal, where onset of withdrawal symptoms is gradual. Signs of active withdrawal include very bad flu-like symptoms, runny nose, nausea, vomiting, diarrhea, chills or sweating, goosebumps, Bone and muscle aches, stomach cramps, restlessness, yawning, enlarged pupils, shaking or tremors, anxiety, irritability, and a strong desire to use the opioid. Emphasizes the patient that a successful induction depends on having moderate to severe withdrawal symptoms prior to first dose, and ask about the patient's prior experiences with withdrawal symptoms. Are there any age specific considerations? So, naloxone is the recommended first line treatment for adolescents and young adults between um, 12 to 14 with mild to severe opioid use disorder. Practitioners are encouraged to develop a relationship with youth and promote screening and early intervention for substance use disorders, especially within the younger population. This program recommends all youth to be screened for co occurring mental health disorders. It is approved for people over the age of 18, and benefits associated with treating opioid use disorder outweighs the risks. Practitioners document informed consent and rationale for treatment. What immunizations and or non-pharmacological treatments are indicated. So immunizations and screening, there are laboratory tests, if not already completed, that include liver tests for screening for potential liver disease, complete blood count, creatinine for kidney function, HIV and hepatitis B, C, serology, syphilis, gonorrhea, and chlamydia testing, tuberculosis, assess clinical factors in order appropriate testing if indicated, and urine drug testing at point of care if available, otherwise at laboratory. There are also psychological treatment interventions and support that work towards breaking the barrier towards medication, encourages patients' willingness to engage, and counseling that aligns with patients' treatment goals. There is also trauma informed practice and adverse childhood experiences. Provides compassionate, patient centered, and non judgmental approach of care with the principles surrounding trauma informed practice. Additional labs and imaging studies. A patient who presented unconscious or secondary to opioid intoxication overdose may need a non contrast CT of the head to rule out potential brain hemorrhages or brain trauma, and a chest x ray for the potential of aspiration pneumonia. IV opioid users with bacteremia require an echocardiogram as they are at risk of developing endocarditis. Non pharmacological treatments continued. So there is recovery oriented care where primary care providers are encouraged to use language that promotes recovery within patients' practices, provides referrals to appropriate services and programs to achieve individual goals, includes care that ensures respect of the patient's autonomy and individuality. It emphasizes skills and strengths while avoiding reinforcement of authoritarian models of care. It encourages patients to work towards a long term, personalized, strength based recovery plan. There's also the harm reduction route, where take home naloxone kits and other harm reduction are educated and teaching is provided. Provides and recommends take home naloxone kit for patients at risk for overdose. Patients with ongoing injection can be referred to needle distribution and harm reduction supply sites, as well as supervised consumption and overdose prevention sites. Are there any pre or post assessments or monitoring required for the patient while they were receiving these treatments? So overview of naloxone induction. So screening is targeted at physical exams and mental health assessment, assessment for common contraindications to naloxone, reviewing substance use history, concurrent substance abuse, diagnosis of opioid use disorder, so DSM-5 criteria, harm reduction, which provides and recommends an naloxone kit, preparation for home-based or office-based inductions. There are also day 1 to day 3 monitoring. There is a long-term care and maintenance plan. There are 1 to 2 week check-ins and periodic urine drug tests, which are generally 4 per year for take-home doses. So preparing for naloxone induction. Explain how naloxone works, so discuss the risks and benefits, complete assessment and investigations, complete a treatment plan after shared decision making, review withdrawal assessment scales, clinical opiate withdrawal scale, COWS, or subjective opiate withdrawal scale, SOWS, consider whether offering unobserved take-home doses for part of induction would be beneficial, and provide education and contact info if considering home induction for day 1 or first dose. What patient teaching is indicated given your disease as it relates to the medications. So keeping your doctor informed. All patients treated with opioids for pain require careful monitoring by their healthcare provider for signs of abuse and addiction, as well as to determine if the analgesics are no longer needed. So carefully follow directions because opioids are associated with significant side effects. Depending on the amount taken, it could cause very severe respiratory distress. Do not crush or break the pills, as this can alter the rate at which the medication is absorbed and could increase the risk of overdose. Also reduce the risk of drug interactions. Do not mix opioids with alcohol, antihistamines, barbiturates, or benzodiazepines, as all of these substances slow down the breathing rate and their combined effects could lead to life-threatening respiratory depression. So signs and symptoms of opioid use disorder. So the diagnosis of an opioid use disorder is based primarily on a combination of the medical history provided, past drug use, history of hospitalization and previous injury, and physical assessments completed by a nurse or doctor. To officially make a diagnosis of an opioid use disorder, the patient must meet the diagnostic criteria of the DSM-5. It is most important for nurses to be aware of medical conditions caused by opioid use, potential adverse effects, withdrawal symptoms, signs of opioid intoxication, or signs of opioid overdose. As you can see, Lisa added a bunch of info on specific things to look for, and symptoms and signs as well. So medication classes, opioids. They are classified as agonists, mild agonists such as codeine and hydrocodone, and strong agonists such as morphine, hydromorphone, hydrochloride, oxycodone, meperidine, fentanyl, and methadone. So what do opioids do? So the amount of pain control or unwanted effects depends on the specific drug, the receptors to which it binds, and its chemical structure. As said in Sealock and Seneviratne, 2020, page 174. As we talked about previously, the common side effects are listed below in the chart, and also some uncommon side effects. Why are patients prescribed opioids? So patients are generally prescribed opioids as a form of pain management. The main use of opioids is to eliminate moderate to severe pain. Strong opioid analgesics such as fentanyl, sufentanil, and alfentanil are used in combination with anesthetics during surgery to relieve pain and maintain the balanced state of anesthesia. Morphine, meperidine, hydromorphone, and oxycodone, which are strong opioids, are used to treat post-operative pain. Opioids such as codeine are used for cough suppression, preventing coughing by suppressing the medullary cough center of the brain. It's also used to treat diarrhea. Opium, belladonna tincture, and diphenoxylate, atropine, Imodium tablets are used to decrease GI motility. So what is the therapeutic effect? It alters pain reception, increases pain threshold, alters pain perception, emotional responses to pain, reduces intensity of incoming pain stimuli from sensory nerve endings, altering pain perception, suppresses the medullary cough center in the brain, reducing coughing, and decreases GI motility and secretory activity. So the action, onset, duration, peak, and half-life. So the pharmacokinetics and the pharmacodynamics are listed here for each of the different types of opioids. So if you want to take a look at that, you're welcome to. So continued on the action, onset, duration, peak, and half-life. Fentanyl injections have become popular in treatment of postoperative procedural pain management because of their rapid onset and short duration. Transdermal fentanyl is available in patch form to be used in the long-term management of pain. Morphine and hydromorphone are first-line analgesics in the postoperative setting because they are available via injectable forms and are also fairly fast-acting as seen in the chart. The brand name OxyContin or oxycodone is sustained release form and contains more oxycodone hydrochloride than the immediate release formula, so it's intended to last up to 12 hours. Removed from the Canadian market and replaced with Oxy-Neo, which is designed to reduce misuse. When crushed and mixed with water, it becomes gel-like and hard to inject. So lastly, here's our reference page. Thanks for listening, guys. I hope you enjoyed it.